I'd like to welcome everyone to our next round of training for the Pennsylvania Trauma Expansion Project. And today we're going to be focusing on the Trauma-Informed Decision Protocol. This is going to be, yet again, a modular-based training, and it's going to be providing all of the probation staff, whether they will be rating the Trauma-Informed Decision Protocol or consuming and looking at and interpreting information from the Trauma-Informed Decision Protocol and utilizing it to make strategic decisions about case planning. There will be different components and different modules in this training series that will be very helpful for you. But I'll start with just a little bit of a roadmap for where these four modules will be going. In the first module, I'm going to start with just an overview of the TIDP. This will be referencing kind of the big picture. It's where we are at in working with Pennsylvania in terms of the overall trauma screening expansion project. And so this will be revisiting some key components, some key pieces of information that has set up and has been informing the entire project. And then we'll do a brief introduction to the Trauma-Informed Decision Protocol, or what I will be referring to as the TIDP through the rest of the presentation. Module 2 is going to be the very practical working through the TIDP steps. So this module will be very important for individuals who are actually completing the intake process, and for individuals who will actually be integrating information and rating the different components of the TIDP. The third module is going to be stepping back a little bit and looking at a little bit more at a bigger picture around really understanding traumatic event exposures and trauma reactions as responsivity factors. This will be some practical information about what we know from the practical day-to-day experiences of working with justice-involved youth who have experienced trauma. And it's also going to be drawing on and integrating information from the available literature to really help us to understand exactly why we can think about traumatic event exposures and trauma reactions as responsivity factors via the R&R model. And the fourth module is going to culminate in really thinking about how information from the TIDP can be linked to and inform a youth's initial case planning and the overall case planning process. And so that's a brief overview of where we're going to go with these four modules. And so we're just going to jump right in. This very first module is going to be rather brief, but it's just going to be providing a basic top level or big picture overview of the TIDP, or the Trauma-Informed Decision Protocol. And one of the first things we're going to do is to kind of revisit some key information that was presented in the last training, just to kind of remind us about the big picture. And so we'll start with just a top-level overview of what we know about traumatic event exposures in justice-involved samples. You all have been working with the CTS in your counties at this point as well, and we've been sort of tracking this, and likely what your experience in your individual probation departments is showing. It's very consistent with national data that universally, almost all youth in the juvenile justice system, or who touch the juvenile justice system, have exposure across the lifetime to at least one traumatic event exposure. What we also know is that the type of endorsed traumas are pretty similar, except in those two important categories: family violence exposure and sexual abuse. Girls much more likely to endorse these types of exposures than boys. But those interpersonal traumatic event exposures, community violence exposure, family violence exposure, physical abuse, being a victim of a violent crime. These are all endorsed pretty equally across boys and girls, anywhere between about 30 to 60%. Even though that lifetime exposure to a traumatic event is almost universal in justice-involved populations, the overall rate of diagnosable post-traumatic stress disorder is not as high. Research varies, but lifetime rates will vary anywhere from about 11% to a high of about 50%, with that drastic difference being related more to the types of samples and a little bit about the assessment methods. But what we see is over the past year that rates of post-traumatic stress disorder are between about 11 to around 15% among justice-involved samples. And that past year rate really does not drastically different in some samples by gender or by race. In other juvenile justice samples, we tend to see much higher rates of identified post-traumatic stress disorder in girls, relative to boys. But what we also know is that many youth who are diagnosed with post-traumatic stress disorder are also showing other mental health difficulties as well. So in our TA calls with many of the counties, what we're seeing is that this is being reflected in CTS results, where elevations on the CTS are occurring alongside elevations, caution and warning scores on the MAISY. And that's just an accurate representation of how common it is that we see trauma reactions and other associated mental health problems occurring among youth in the juvenile justice system. And why are we focusing on this overall? Is because what we know is that many youth are going to experience traumatic event exposures. A smaller but still substantial subset of those youth who have experienced traumatic event exposures will go on to start to experience clinically significant trauma reactions that can be diagnosed as post-traumatic stress disorder. And the combination of these two things together can increase the likelihood that a youth may come into contact with the juvenile justice system. And as we talked about when we started to implement the CTS, is because of these high rates and because of the functional impairment that can occur for a youth, this is why systems have started to universally screen for trauma. And it's an effort to, once a youth does become in contact with the system, to try to screen and identify and then refer youth for appropriate services as a way to try to disrupt this circular cycle that can continue over and over again for youth. And we talked about this in the last training as well. Trauma screening is considered an essential element of a trauma-informed juvenile justice system. What we'll be talking about today with the trauma-informed decision protocol is this is just an extension of trauma screening that will help juvenile probation officers integrate information across a range of different types of assessment tools to move into a next essential element, which is reinforcing the linkage that trauma-exposed youth who are screened positive should warrant additional follow-up assessment and an appropriate linkage with services that addresses not only their trauma needs, but also the criminogenic needs that could be contributing to their risk of future delinquent behavior. And so let's just revisit this, just as a little reminder, what exactly it is that we mean by screening. Of course, we know that screening is a brief process. It's intended to be quick and efficient, and it's something that can be done by non-clinically trained staff with an appropriate response. And that a good screen is, its whole purpose, it's to identify or flag youth with a result that might suggest the presence of a particular problem, like traumatic event exposure or trauma reactions. What we also know is that good screens have demonstrated reliability and validity. They're accompanied by processes and procedures that will help juvenile probation officers introduce the screen, administer the screen with some consistency and fidelity, and then to follow up on the screen as well. And that a good screen is also accompanied by decision points that are well known and that have some good validity in appropriately catching or identifying the youth who are most likely to be suffering from the difficulty that you're concerned about. And of course, What we've done here in Pennsylvania is, in our pilot counties, is we have implemented the CTS, or the Child Trauma Screen, which has a combination of items that are addressing traumatic event exposure and also addressing current trauma reactions as well. What we know is with the screen that youth who are scoring above a 6 are moved into a follow-up process, which of course we all know now as the secondary screening process. And all of that information together is utilized to make a decision about identifying the next step or a possible referral of that youth to further trauma assessment. And through our last training, what we've done is we have articulated 6 major steps or components to the trauma screening process with the CTS. That starts, of course, with the introduction, and then administering the screen, and then how we also follow up on the screen as well. And all of this, of course, has been explained in the last training as moving into the ability for Pennsylvania to, of course, be identifying the trauma needs of youth, but then also moving this towards a greater integration of this information into their case plan. And Pennsylvania is an excellent example of a state that has been utilizing the risk needs responsivity model as a way to promote effective case planning. And what do we know is this is information that is all well known among individuals who are working in probation in Pennsylvania. But the risk needs responsivity is divided into 3 different principles, with the first, of course, being the risk principle. And the risk principle is giving us an indication about who we need to intervene with. And the risk principle, of course, indicates that the intensity and the dosage of intervention or treatment services needs to be matched to that overall risk level. And once we identify what youth we are going to be intervening on and at what intensity, we need to, of course, identify how we are going to intervene as well. And that's, of course, the needs principle. And what does the needs principle indicate to us is that we should be focusing on our intervention efforts on those dynamic, changeable risk factors that are associated with future recidivism. And finally, we have the responsivity principle. And as we've talked about before, the responsivity principle provides a framework for how treatment should be delivered. And treatment should be both generally responsive and also responsive to the specific needs that a youth has as well. And what do we mean by general responsivity? That's kind of the idea, is that in general, any treatments that are targeting a criminogenic need really need to focus on skill development and be delivered in a way that is responsive to the individual needs of the adolescent. And how does a treatment program do this? They will do that by recognizing that there are specific responsivity factors, individual characteristics that are present for youth or within the youth family or within the youth environment that could have an impact on the way that they approach to the services that are being offered to address their criminogenic needs. One of the big challenges that we've had as a system is designing and bringing in different types of screening and assessment tools to address the different types of needs that youth have. And so traditionally, and now as is evident in Pennsylvania, we have 3 different types of screening tools in operation in intake. We have, of course, a risk needs assessment, the youth level of service case management inventory, designed to identify the level of risk for future delinquent behavior, the types of criminogenic needs that are going to be important to focus on in terms of a youth case plan. We also have counties screening for mental health problems via the MAISY as a separate screening tool. We all know the purpose of the MAISY is to flag youth at different levels of caution or warning scores to reflect the youth that we need to consider for follow-up for possible further mental health assessment. Now with the CTS, we also have trauma screening as well, identifying a history of traumatic event exposures and also current trauma reactions in youth as well. And now we have 3 different tools, all addressing different types of needs. And one challenge that is faced by systems is, how does an individual probation officer make decisions about prioritizing needs from all 3 sources of the screening and intake information? And of course, then with these 3 different need areas, and with the relevance of thinking about the R&R model, the focus, of course, is to try to address those criminogenic needs. And that pattern has been reinforced not only through best practices, but also the empirical literature as well, that suggests those criminogenic needs are the factors that are most likely going to increase a youth's risk for engaging in future delinquent behavior. Right? But we also know that responsivity factors are important as well. And the CTS and the MAISI are going to be providing us information about specific responsivity. So a challenge is, do we just think about a mental health assessment referral, or a referral for mental health treatment, or a referral for a trauma assessment following up on the CTS? Well, what happens when you have a youth who is high risk on the YLS-CMI, has scored above a 6, and has required secondary screening on the CTS, and also has 3 caution and warning scores on the MAISI? How does an individual probation officer try to integrate that information in a way that doesn't overburden the youth and the family, but also ends up designing a case plan and follow-up strategy that's consistent and stays true to the R&R model? That's where the trauma-informed decision protocol comes into play. And what we can do is, of course, I've mentioned this many times now, is that trauma reactions and other related mental health difficulties are really best identified as specific responsivity factors. And so what we are trying to do here is we're trying to understand this interplay and this intersection between traumatic event exposures, trauma reactions, and the different types of criminogenic needs that are identified on the YLS-CMI. And by referencing this slide, we can see kind of a conceptual model of how these factors are related to one another. And there are really 3 overarching principles that will emerge from R&R that will help us to set the frame for this integration. First, of course, is what we know is that the criminogenic risk factors are what are going to predict a youth's level of risk for future delinquent behavior or reoffending. This is just entirely consistent with the risk principle. The more of these risk factors that you have, the greater level of risk that's involved. And we consider this to be a direct effect. And in other words, on this slide, that there's a direct line between criminogenic risk on the YLS-CMI and leading directly to offending. The second principle here is that trauma reactions, we could think about that as specific types of trauma reactions that are identified on the CTS, or the overall severity of PTSD symptoms that might be identified on follow-up by a clinician. One of the reasons that we consider this a responsivity factor is because this model would suggest that trauma reactions or these types of symptoms are not going to directly predict reoffending outcomes. Right? But what will be that significant direct predictor is those dynamic criminogenic needs. And so this is consistent with the risk and the needs principle. But trauma as a responsivity factor, it's going to identify that those trauma reactions, when they are present, that they are going to serve essentially a destabilizing function in the life of a youth. They're going to impact the way that the youth is currently thinking, feeling, and behaving on a day-to-day basis in a way that could actually magnify and aggravate or increase the strength of dynamic criminogenic needs on that risk for reoffending. And so this is the basic model for why we think about, trauma screening, but it's also as a way to be thinking about how we should be interpreting or kind of thinking about how trauma reactions can be linked and understood in relation to criminogenic needs. And of course, where do those trauma reactions come from? They start from particular lifetime histories of traumatic event exposures. And from what we just talked about before, as a reminder, it's those traumatic event exposures that are increasing the likelihood that some youth will develop trauma reactions. What we also know from the literature is that traumatic event exposures can increase the likelihood that a youth may start to experience certain types of criminogenic needs as well. And in fact, as we'll be talking about in Module 3, there's kind of a bidirectional relationship between different types of traumatic event exposures and different types of criminogenic needs that are identified on the YLS. And ultimately, and what makes our job a little more complex in how to try to integrate and synthesize information across these three different sources of assessment or intake information is we have criminogenic needs that are increasing the risk for reoffending. The criminogenic needs may be informed by and interact with different types of traumatic event exposures. And the combination of both traumatic event exposures and criminogenic needs can increase the likelihood that some youth will experience trauma reactions. That might aggravate or exacerbate the path between criminogenic needs and reoffending. The R&R model and some of the research that supports the R&R model would allow us to essentially unpack and acknowledge that all three of these different types of patterns or pathways into future offending behavior can occur. And it's with recognition of the complexity of the interactions between these variables that has led us to develop the trauma-informed decision protocol. The TIDP is essentially a 9-step decision-making process that integrates information from the trauma screen and the risk needs assessment and the mental health screen. And it provides a way of organizing and synthesizing the information that is being generated across the tools into a framework that will highlight the extent to which probation officers should be concerned about traumatic event exposures, trauma reactions, or mental health difficulties as a specific responsivity factor that could be driving or aggravating certain criminogenic needs identified on the YLS CMI. The TIDP, in essence, is a way of ensuring that case plan decision makings are incorporating all three of the principles from the R&R model: the risk principle, the needs principle, and the responsivity principle. And in Module 2, we'll be going over how to essentially go step by step through this information, but we've organized the 9 decision steps into this framework that can be plotted on a single page that will provide decision makers with a visual representation of the outcomes from these 9 steps that will integrate and support some decisions about further assessment or treatment, and also for case planning. And that's essentially the overview of how we've led up to the TIDP. A bit about the steps that are going to be involved in the rationale for the TIDP and how it is going to move the probation departments in Pennsylvania one step closer into a true trauma-informed or trauma-responsive case planning process. And so now what I'd like you to do is to follow the link on the slide and to the knowledge check questions for this module.